So, Dr. Scholz, today we're going to be talking about hormone therapy, but specifically about the side effects and the management of these side effects. Now, out of all the prostate cancer treatments, it seems like hormone therapy has the most intense side effects. You get hot flashes, fatigue, and because of the fatigue, your body changes and there's all sorts of things happening. So I thought we could break down these different side effects and talk about ways to mitigate them. Some may be easier to do than others, like weightlifting, but I think giving the big picture of all of the steps that someone can take, it's a big difference in the outcome of whether hormone therapy is more tolerable or something that cannot be tolerated and needs to be changed. So first of all, let's talk about first generation versus second generation hormone therapies. Can you explain the differences and are the side effects different between the two?
Yeah, so when we think of first generation hormone therapies, we're thinking of the medicines that block the release of testosterone from the testicles, and blood levels of testosterone drop close to zero when you're taking medicines like Lupron, Firmagon, Orgovyx, Eligard, Trelstar, and the like. These have been around since the 1980s, and they're very effective. And yes, if you've listed, you can incur a variety of different side effects. When we talk about second generation hormone blockade, we're talking about medicines that go inside the cancer cell and stop the cancer cell from making its own testosterone. That was the big breakthrough when Zytiga came out in 2010, and subsequently we had approvals of Xtandi, Erleada, and Nubeqa. And these medications have taken men who were previously hormone resistant, which really, as it turned out, meant that the cancer had learned how to make its own testosterone, and put these people back into remission again. Spectacular medications, and maybe even more effective when they're used before the onset of hormone resistance. These cells are lurking in the background, even in hormone-sensitive cells, and they become the dominant population after men have been on the first-generation medicines for a long time. So these are spectacular medicines. In terms of additional side effects, not that big a deal, because the side effects come from having low blood levels, and men already have low blood levels from first-generation medications. It's very rare to use second-generation medications without first being on a first-generation medication as well. Additional side effects are proprietary to the different medicines. Zytiga, for example, can cause fluid retention, high blood pressure. It can cause liver abnormalities sometimes. And it depletes the body of prednisones or cortisone, so we have to take a little bit of prednisone with it. All these things are manageable, but they are different than just being on Lupron or on Firmagon or Orgovyx. Side effects of Xtandi, which is another second-generation medication, are sometimes additional fatigue can happen, not invariably. And in people that have a predisposition to seizures, that medicine has to be avoided. Erleada has been associated with a little more rashes, and Nubeqa has been pretty tolerable. All these medicines sometimes will interact with other medications, and you have to take allowance in that regard. But usually, if you add a good second-generation medication to a first-generation medication, you're not going to see much additional side effects, but you will see additional anti-cancer efficacy.
Before I get to my next question, I just wanted to remind you, you can join our cause and help get these videos out to people all around the world. You can do so at pcri.org/donate. Now back to this video on hormone therapy. So let's talk about something that came up in the press. I think I saw it on Yahoo News a couple years ago about the concept of hormone therapy and memory loss. Now, it's to my understanding that the memory loss, or the study itself, may have not been the strongest, but also when I talk to patients who are on hormone therapy, it seems like the memory loss is much more associated with fatigue than the effect of the drug. Is this accurate?
Yes. The studies that report memory problems or Alzheimer's or whatnot are associated with, I think, a genuine loss of memory or difficulty finding words that occurs when we get tired and fatigued. And it reverses when the medicines are stopped and the energy levels return to normal. The problem, of course, is that some men are placed on lifelong hormone therapy, and that will therefore be an ongoing long-term effect. And we've talked many times on this channel about how to compensate for the fatigue and the weakness that is associated with loss of testosterone. And a diligent, focused strength training program is essential to retain a sense of normalcy when you're on these medications. People need to be aware that you can be very diligent and careful and persistent in weight training for 6 to 9 months and feel reasonably normal, and then take a 3-week holiday and observe how rapidly muscle loss occurs, and then you're playing catch up after that. So a lot of people are not aware of how fastidious and how hard people have to work to retain that sense of normalcy when they're on these medicines. But if that commitment is embarked upon and fulfilled, they can retain a large degree of their sense of normal energy when they're on these kind of medicines.
So let's get into the details a little bit with the concept of weightlifting and that resistance training. Is someone working out 5 times a week, 3 times a week? What's the minimum that they would need to work out in order to get a benefit?
Well, you can benefit from any degree of exercise, but to obtain a minimum optimal degree of fitness, it'd probably be an hour in the gym doing traditional weight training, which would be 3 sets of 10 reps on every major muscle group in your body. An hour 3 times a week would go a long ways towards helping people maintain a sense of normalcy when they're on these medicines.
You know, we talk about bone density in other videos. Is that a concern when it comes to hormone therapy?
Oh, certainly. Men, just as women going through menopause, can start to have rapid calcium loss from their bones during the loss of testosterone. And men are starting off with stronger, bigger bones than women, and a number of people will get through it without much problem, but you don't know what your bone density is unless you measure it through a bone density scan, and people should do this at baseline and see if they already have osteoporosis or they're starting with less bone mass, because progressive loss then can put them at risk for fractures.
So how does diet play into this? You know, we have weightlifting and then we're trying to, help the person through this entire process, but the concept of gaining weight while on hormone therapy, it seems like a lot of men I talk to, they do gain quite a bit of weight sometimes when they're on this. So what is the optimal diet for a hormone therapy patient?
Well, any diet that keeps your weight down is an optimal diet. The metabolism slows down, especially if there is a loss of muscle. Muscle tissue is high metabolic rate tissue. And people who simply maintain the diet that they've always been on when they had testosterone will gain weight when they stop testosterone, because their metabolism slows down and they don't need as many calories. And the type of weight that men tend to get around their middle can be very hard to get rid of once it appears, and it is therefore prudent to adapt to a lower caloric diet when embarking upon hormone therapy.
So when we say lower caloric diet, are we thinking 1,500 calories, 1,800 calories? What would that look like?
Well, everyone has different needs, but you certainly want to cut back. And people that want to lose weight, in the simplest terms, if they're eating 3 meals a day, go down to 2 meals a day. It's a radical proposition, I know. Anytime you start talking about weight loss, it's a very sensitive subject, but it is an important one to discuss so that people at least are aware up front. And at some point we should do a video on these new weight loss drugs like Ozempic, which seem to be very effective.
So a couple of tips I've heard from patients that have helped them through the weight training process is maybe going with a buddy or watching a YouTube video, but you've also talked about getting a personal trainer. Can you talk about why a personal trainer would have a much better positive outlook or positive benefit than maybe doing it by yourself?
Several reasons. One is getting on a schedule and having accountability. 2 is there is a specific way to do it to make sure that you're challenged, but that you don't over-challenge yourself and injure yourself, which takes you offline altogether. If it was easy to do these sorts of things, we'd already be doing them, we'd all be doing them. And when men are going through all these other changes, it's an even more difficult time to implement a whole new lifestyle. So a personal trainer is a professional who comes into your life and has experience dealing with different personalities and the demands that people face. And the chances for success would be a lot better if you have professional supervision.
Yeah, I think the personal trainer is a big deal if they can get one. I know another friend of mine, he started doing resistance training with his wife and going to the gym, so at least he had a partner, and his wife was the one keeping him accountable. So I think that also may be helpful to patients who are in those situations. So as far as other side effects go, I know hot flashes are a really big deal. So first of all, they're a really big deal for the people who are experiencing them. I've heard some men don't experience hot flashes at all, and other men, it seems like they're in this constant state. So what percentage of men get hot flashes when they're on these types of hormone therapies, and really what can be done to help mitigate it?
Well, I think it's a third. A third of men don't get any hot flashes. A third of men get a very subtle experience that they're even asking, is this a hot flash? And then another third of men have really intrusive, disturbing hot flashes that can wake them up at night and create problems. Estrogen is the most effective thing. It almost always corrects the hot flashes, but there is a risk of breast enlargement with estrogen. Progesterone is very good for hot flashes. Some progesterone can be converted into testosterone, so that might not be ideal in certain situations. It turns out that acupuncture can be effective for hot flashes. I'm not an acupuncture expert, and I don't know how you find one that's competent in this, but there are trials showing that it can make a positive impact on hot flashes. There's some routine pharmaceuticals that are approved for other purposes, like gabapentin, Effexor, which is a mild antidepressant. It's not universally effective, but sometimes it's quite useful. So all of these things, either alone or in combination, can make a big difference if you're in that 1/3 of men that's really struggling with hot flashes.
So with like estrogen or progesterone, are they creams, are they injections, are they patches?
Good question, because estrogen pills need to be avoided. They can be associated with blood clots, but estrogen patches, which go through the skin, are not associated with blood clots. In Europe, they have an injectable form of estrogen. This has never been FDA approved in the United States, but the impact of estrogen is 80-90% of men will notice a dramatic reduction in hot flashes.
I think a lot of men who are going and they're on hormone therapy are seeing urologists. Is the hot flashes and these types of things something that a man would go talk to his urologist about, or would he need to see his primary care physician?
Either one. The management is a bit of an art. How engaged that particular urologist is going to vary. I don't think it's an easy call. Should you go to an endocrinologist or an internist or a urologist? I think that in some cases, doctors are so busy that you, the patient, are going to have to instruct your doctor about the possibility of some of these medications.
So for men who are on progesterone, do you suggest that they get their own testosterone levels then and they kind of monitor how that's going?
No, I'm not sure that you'd be able to detect the testosterone in the bloodstream. The studies that were done were back in the era when we only had Lupron, first-generation hormone therapy, and there were some occasional cases where it seemed like the cancer was growing in men that were on Lupron who were taking progesterone. Maybe that won't be the case if you have second-generation medicines on board, Xtandi, Zytiga, Erlita, or Nubeqa. So the literature on this is very fuzzy.
So you mentioned breast enlargement with estrogen. Can breast enlargement happen in just having hormone therapy or taking hormone therapy? And also I've heard of prophylactic radiation to the nipples. So when does that come into play with this particular case?
Absolutely. The possibility of breast enlargement exists with all types of hormone therapy, including, you mentioned, estrogen as well. We typically will start off with an estrogen blocker, which is called Femara, or letrozole is the generic name for that. Other doctors I've seen have used a medicine called tamoxifen. Other doctors have used another medicine called Arimidex. And these pills which block estrogen in your system usually don't have any side effects and are pretty effective at preventing breast enlargement. Use of radiation was developed prior to the awareness that these pills would be good ways to prevent breast enlargement, and the radiation works pretty well. I'm sometimes concerned that the doctors giving radiation are underdosing a little bit because there can be some breakthrough breast enlargement despite previous radiation in certain individuals. Radiation only works if it's used before the breast enlargement develops. You can't radiate away breasts once they exist. And it needs to be emphasized that some men seem to think, well, this is something that will come and go with the treatment. I can endure the cosmetic abnormality of having an enlarged breast, and I assume it will go away when the treatment stops. And the answer is it won't go away. It is permanent, and the only way to correct for it is with plastic surgery. Interestingly, too, you'd think plastic surgery would be a rather straightforward proposition, but I've had men go through plastic surgery for enlarged breasts and have a pretty terrible cosmetic outcome. I think it's because the plastic surgeons aren't doing a lot of breast reduction surgery in men. So you have to find an experienced plastic surgeon to do that type of an operation if you're going to go down that pathway.
So for men who are looking to get that type of radiation to their chest to avoid this issue, who would they go to and who do they have that conversation with?
Any competent radiation therapist, it's a simple type of radiation. They just fire the radiation tangentially across, so it just catches the tissue. It doesn't even go into your deeper part of your body. It's a methodology that's been around for 25 years. It's not going to present any difficulties. And finding competent doctors to do that.
Have you seen it typically covered by insurance?
Yes, it should be covered by insurance.
Other issues that happen a lot of times especially in hormone therapy, is the depression or the fatigue a lot of times causes depression. How often are you prescribing antidepressants when it comes to hormone therapy patients, and what would taking care of your mental health through this process look like?
Well, there are emotional changes that, testosterone induces the male, I can tough this out attitude, and many men have commented to me when they're off of testosterone, in other words, taking hormone blockade, that they have stronger feelings, that they're crying in movies for the first time. And some men like it, some men dislike it, and some men don't really care. So I think it's a very personal thing. I don't think that particularly is a depressive, it's just a difference. Concerns about depression, people already have prostate cancer, they're going through different kinds of treatment, they're facing uncertainty. Certainly depression would be a possible reaction, but it's not from the medicines itself, it's from the situation. The emotional swings can be tamped down with mild antidepressant medications. I've had a number of men who found the stronger emotional response unsettling, and in whom we've administered tiny doses of antidepressants, who later comment that they feel normal again. So that is a resource for anyone that feels like they're struggling with stronger emotions than they're used to.
So when we say tiny doses, what are those antidepressants and what is the dosage that they're looking at?
Zoloft, Paxil, Prozac, minimum starting dose seems to have magical corrective effect in men that are complaining of these emotional swings.
So let's talk about the sexual side effects. When testosterone obviously leaves the body, that puts the man into a different situation. In previous videos, we've talked about the difference between libido and potency. Can you cover that, lightly here, but really go into what a man can do in the process of maybe he's with his partner and he doesn't have the libido that he normally has and he's on hormone therapy? This is an ongoing issue for many patients, as you know.
The libido will be restored if there's a stop date on the hormone therapy. Vast majority of men will recover their libido normally. Some men may have a somewhat diminished libido after full recovery of testosterone. The absence of libido is a mysterious happenstance for a number of men after they've been on the treatment. They come in wide-eyed thinking, well, I know you told me about this, but it's really true. I'm completely have no attraction to women at all, which they've had since they were 10, 12 years old. In terms of compensatory things, I counsel men to try and do something to continue getting erections during this time. Getting erections is associated with being interested in sexual activity. And if there's no interest in sexual activity, it's easy for this to be tabled. But it seems that long periods without getting erections, and many people are unaware of the fact that men are getting erections every night when they're sleeping. But when you take away their testosterone, those nighttime erections are not happening, and permanent long-term atrophy can occur through the absence, use it or lose it. So we typically will put people on Cialis 5 milligrams a day to try and keep the normal cycle of erections. And we counsel people it's perfectly fine to be sexually active, but it is difficult. Oftentimes the male libido is the strongest in the family, and that when that flies out the window, then it's very common for people to forego sexual activity when they're on hormone therapy.
So when we're talking about atrophy, what exactly are we looking at?
The size of the penis getting smaller, and then not recovering completely after testosterone comes back. Possibly a greater incidence of lasting impotence where men are unable to get erections. These are obviously very serious ramifications, and it hasn't been proven that being on Cialis or Viagra during the low testosterone period will correct for these things, but we do know that a number of men are emerging with problems with impotence and smaller erections, and this is something that seems like a prudent thing to do, to stay on Cialis during the treatment period.
Is there any coming back from that if it does happen? Because I have had men call a helpline and they said that they've dealt with atrophy and now they're off the hormone therapy and they don't know what else to do.
Well, I'm not an expert in this area, but I do think that if people cannot restore their erections with medications, pills like Viagra and Cialis, that it would be wise to consult with a urologist and learn how to give injections. Because if you inject small doses of prostaglandins into the penis itself, it will create erections on a regular basis. Seems like a rather extreme step to take, but I think that it's likely to be effective. and that people are planning for the future. There's going to be a day when the libido returns and people want to go back to a normal lifestyle.
Besides sexual side effects, are there any urinary side effects that will be associated with hormone therapy?
We've occasionally encountered men who describe getting up at night more frequently, changes in urinary patterns since starting on Lupron or these other hormonal agents. Why that is, we're not quite clear. It's not a universal effect, but we do occasionally have people comment on that.
So in this video, we've talked a lot about the negative side effects when it comes to hormone therapy. And I don't want to give a patient the wrong impression that, it's all about the side effects. Can you talk about the benefits of somebody going on hormone therapy and the incredible impact it can have on their prostate cancer?
Well, all the other cancers, breast, colon, lung, and whatnot, they're all jealous of prostate cancer because they don't have hormone therapy. There is hormone therapy in breast cancer, but it's about 20% as effective as hormone therapy in prostate cancer. People are usually going directly to chemotherapy. So hormone therapy is generally less toxic than chemotherapy and typically quite a bit more effective than chemotherapy. You can get responses that routinely last 10 years with hormone therapy. Would that we had something like that in other cancer types. So it's a very, very effective treatment, and the side effects typically are reversible if people manage the side effects sensibly. We're very blessed to have a treatment like this. It has to be used judiciously. We have to profile the patients and figure out who really needs it and avoid it in those that don't really need it, and not overuse it when after a certain period of time the benefit has been accrued and you can stop. I do run into people that have been on hormone treatment for years and years, not realizing that they can take a holiday. It seems that after about 18 to 24 months, you've pretty much squeezed all the value out of the hormone therapy, and you can take a holiday at that point and monitor things closely. Studies clearly show that that's a safe proposition.
If you would like more information about intermittent hormone therapy, more details on how these hormone therapies work, the PSA response, and their effectiveness, you can search our YouTube channel. We have many other videos besides this. Thank you, Dr. Scholz. Thanks for watching to the end of this video. A couple of tips I wanted to give you. When I think of prostate cancer and hormone therapy and I look at all the side effects, there are some things that I know just being a prostate cancer educator that really help patients because I've heard so much feedback over the years. So number one, if you can get a partner to talk to about your mental health, maybe go to the gym with you, go for walks with you, or even somebody to support you as you go through these emotional changes, it's really beneficial. When I say you're not alone, I say you're not alone because number one, I am rooting for you, the PCRI is rooting for you, but also there are prostate cancer advocacy groups who also are rooting for you, and they have some really amazing supportive services. Now, when we hear supportive services, sometimes that can be general, like, oh, supportive services, that sounds good. No, it's a support group of people who have been through your situation, and you can either go in person, you can call in, you can join a Zoom call, or there's forums. So there's groups like Answer Cancer, Male Care, Cancer ABCs. There's all sorts of supportive prostate cancer support groups with men who have been in that situation, and you can contact them, get in a group, and hear about other patients' stories and hear about their situations, but also what they did to help mitigate the side effects. The other thing is if you maybe don't want to join a support group or you don't have somebody you can talk to, you can call our helpline. PCRI.org/helpline. These are men who are prostate cancer facilitators. They've been trained by our medical oncology team and all of our advisors, but they've been on hormone therapy, and they have definitely done things to help mitigate those side effects. So if you don't have access to maybe some of those other resources, PCRI is here to help. Also, watch our other prostate cancer videos on hormone therapy because they can go into more detail about what we're talking about. Now, as you go through this whole process, I'm going to ask you, do me a favor. Think of the big picture and think of yourself holistically. Please care about your mental health. Get the supportive care you need. Talk to your doctor about how your heart's doing, how you're doing through this process. Go to the gym and work out. I know it is hard. I have worked out and been with patients who are on hormone therapy at the gym working out. I see the difficulty and I can't even imagine. But it's going to benefit you so much. I want you to come out of this whole process feeling strong and feeling like you beat something, and that even though maybe the odds were stacked and you had hormone therapy and the testosterone's low, you still were able to take care of yourself. In fact, we have a video on our channel by a guy named Steve Schwartz if you want to look it up, and we'll link it in the description below. And he went to the gym on hormone therapy, and he really had great benefits even outside of hormone therapy when he was off of it. Talk to a nutritionist, find out what diet works works for you. Think of the overall big picture. It's not you have prostate cancer, we have to treat it, and you're stuck with whatever's there. That is not the entire point. The entire point is you have a good quality of life. Now, as you go through this process, please remember our YouTube channel is here. Please search our videos. There's more information to come. If you would like to donate and join our cause, you can do so at pcri.org/donate. When you do this, we're trying to get this type of information out to millions of men all across the YouTube platform. And thanks so much for your support. I know that these videos sometimes, I don't know if they're hard to watch or easy to watch, but I'm glad that we're here to help you. Please thumbs up this video if you thought it was helpful, and please comment. The more comments we get, the more type of, questions we see, and then we can create that content to help answer your questions. Thank you so much. I hope you have a great week, and most of all, remember, you're not alone.